Hi everyone, my name is Zainab, and just to reiterate, I will be presenting on the depression and substance use outcomes of work transitions. And so just to begin with a bit of background on this topic, along with the nature of our population and our intervention, recently released women have higher rates of depression in community samples, and given the stress of incarceration, it's not surprising that a lot of women experience depression, anxiety, and PTSD, both during and after incarceration. And overall, it's a very under-researched topic for women in the criminal legal system. Incarcerated populations are also medically underserved. They lack a lot of access to medical, substance use, and mental health treatments. And recently released women specifically have poor mental health indicators as well as HIV risk and substance use. Those who are diagnosed with mental health disorders also have a greater comorbid risk for substance use disorders, and that is actually greater among women. And those who have these co-occurring mental health concerns and substance use concerns also have a higher risk for HIV, and the HIV prevalence among recently released women is about 4 times as high as the general population. And it's estimated that about 50% of recently released women who have mental health disorders also have co-occurring HIV risk behaviors. And this population in general faces like a myriad of barriers of care. Patients with comorbid substance disorders and mood and anxiety disorders demonstrate poor treatment adherence and higher rates of treatment dropout for a lot of different factors, both before, during, and after incarceration. So, for example, a lot of women, their insurance will not follow through when they're in incarceration, and so they can't afford the medical treatment within incarceration. They also face delays in transfer of medical records, or once they actually gain access to treatment, a lot of times they can face stigma from medical care providers. And then outside of incarceration, they also have the issue of not being able to access treatment because of things like having to go to parole and probation offices and having curfews for their transitional housing, or not having access to transportation. And in general, there is a gap in the literature addressing depression specifically in recently released women. So in order to meet some of these complex needs, we have implemented Worth Transitions, which is the combination of 2 evidence-based programs. The first being Women on the Road to Health, or WORth, which is an evidence-based trauma-informed intervention for women in the criminal legal system. It's aimed at reducing HIV risk, so it's aimed at reducing sexual and drug risk behaviors as well as intimate partner violence, and it's also aimed at increasing condom use. These are the core elements of the WORth sessions. There's 5 sessions over the course of 6 months. The first one is a one-on-one session with our community health workers, which I'll talk about in a second, and then the rest of them are group-based, and they're all about HIV education, prevention, and treatment. They get tested for HIV as well as hepatitis C, and they also go through different risk assessments for substance use and intimate partner violence, and also workshops for skill building around condom use, relationship safety planning, and social support. The second half of our intervention is the Transitions Clinic, which provides transitional and primary care and case management for recently released individuals. And this is aimed at increasing their motivation to address their healthcare concerns, as well as to increase their access to medical, mental health, and substance use treatments. Formerly incarcerated community health workers who have similar histories of incarceration and addiction will provide support and healthcare management in the clinics, as well as guide the sessions. And again, Worth Transitions is the combination of these 2 programs, and it's been expanded to be more trauma-informed, as all of our providers are trained to be more trauma and culturally sensitive when engaging with this population. And it's also been adapted to be more inclusive of recently released women. So moving into the current study, given the gap in the literature addressing depression specifically with these women and their complex co-occurring issues, the present study aims to examine the enrollment in Worth Transitions and its relation to depression symptoms and substance use, as well as any interactions between depression symptoms and potential moderators through regression analysis. And moving into methods, our participants were recruited in Rochester, New York, and New Haven, Connecticut by research assistants or community health workers from sites like jails, prisons, and other community locations where recently released women often frequent, such as transitional housing or probation and parole offices, and also a few indirect methods such as social media ads and flyers. And participants were incentivized with gift cards for their participation at different levels of the intervention and for going through different assessments. This was not a randomized control trial, so all of the participants were given complete access to our intervention. And on the right, you can see that about 260 women were screened and 208 women enrolled and met our inclusion criteria, a little bit more in Rochester than in New Haven. 206 completed baseline measures and about 112 completed all of our follow-up measures. So these are our variables of interest, including the measure and the model. So the first one's blocked on the screen, but depression was measured using the depressive symptom scale, which is a 9-item scale that asks questions about their symptomology. Substance use was measured as a proportion of the days used in the last 90 days out of 13 substances. And then some of the potential moderators that we wanted to examine include their exposure to the intervention, which we categorized into attending the work sessions, attending the clinic, or attending both. And both PTSD, symptomology, and HIV risk behaviors were modeled using a 4-item scale. And then in terms of statistical analyses, we examined the change in depression and substance use symptoms pre-post intervention. And we also performed bivariate regressions for each of the covariates relationship to depression change over the course of the intervention. So moving into the results, we didn't find any significant differences in the population characteristics between those who completed baseline measures and those who completed follow-up measures, but our mean age was 37 years, and the population was predominantly white, heterosexual, and single. Here are our main primary outcomes of depression change and substance use over the course of the intervention. As we can see from the first table, the mean score on the depression symptom scale did decrease, and that was found to be significant. So overall, comparing pre and post, the women's depression symptomology did decrease. And the same thing for substance use change, the mean also did decrease. And when we examined the change in depression scores by the continuation or discontinuation of substance use, we actually found that using drugs at baseline and then not using drugs at 6-month follow-up actually changed the mean depression score the most, which goes to show how treating substance use can also help alleviate those depression symptoms because it was so co-occurring in our population. Now moving into some of our bivariate regression analyses, we wanted to examine the change in depression scores by different substance use types. And so we categorized it into alcohol, marijuana, hard drugs, and prescription drugs. And we actually found marijuana use to be significant in that it might be predicting that change in depression score over the course of the intervention, which could be due to a number of factors such as less depressed individuals using marijuana versus hard drugs, or marijuana being used in more social contexts, which could possibly lead to higher levels of social support, which has been shown to alleviate depression symptoms. But overall, the limited literature on marijuana use in this population does show that it's more of an adverse outcome than a beneficial one. And so more research would be needed to see like if there was an actual association between marijuana use and drug use in a population that has other co-occurring substance use and other co-occurring chronic conditions. And then we also examined intervention exposure and how that may be predicting depression change over the course of the intervention. And we found sessions only to be approaching significance, which is an interesting finding for the intervention itself. As the sessions were both group-based and peer-led, it may be more helpful for these women who have sometimes a mistrust in medical professionals or who have a history of trauma or negligence when it comes to medical settings. And so having a session where they have other women who they can relate to, have gone through similar experiences, may be more helpful. Then when we examined change in depression by a few sociodemographic characteristics, we found race to be approaching significance. There is a limited amount of literature that does link different racial and ethnic groups to having higher rates of psychiatric or chronic or co-occurring chronic conditions. And so a intervention like birth transitions could benefit from tailoring their intervention towards different racial and ethnic groups that may have higher levels of mental health concerns. And lastly, we also looked at the change in depression by PTSD symptomology and HIV risk behaviors, in which we found HIV risk behaviors to be approaching significance. And that's also concurrent with the literature that those in this population who have mental health disorders also are at greater risk for HIV. And interventions like work transitions that are aimed at decreasing HIV risk behaviors, it would be beneficial for them to also be addressing mental health concerns, as they can sometimes be associated with each other. So moving into the discussion, there were a few study limitations in this, for the study. We did have a low sample size and missing follow-up data due to the difficulty in obtaining follow-up in this population, specifically during COVID. It's really difficult to keep in touch with this kind of population. A lot of the times they move, they no longer have access to the internet, they may unfortunately go back into incarceration. And so a lot of times it's difficult to maintain contact with them for a longer period of time. We also had an English-speaking inclusion criteria, which may have limited some of the populations we were able to serve, such as monolingual Latinx individuals who we would not have been able to participate in our study. We also utilized some self-reported behavioral data in some of our measures. But overall, we did find our main outcome of depression and substance use symptoms to decrease post-intervention. We also found a few different covariates to be separately interacting or approaching significance with depression symptoms at 6 months compared to baseline, which really does underscore the promise of an intervention like work transitions on the mental health of women in the criminal legal system who have co-occurring substance use and depression. In terms of future studies of work transitions and work specifically, it would be helpful to address depression and substance use needs of recently released women, especially in terms of integrated care. The results also inform the study of other interventions for care of recently released women, specifically surrounding like HIV risk, substance use, and mental health, because it is a very underserved and under-researched population. An additional cross-sectional and longitudinal studies with a larger sample size would be needed to examine other potential moderators on the change in depression scores in these women, as well as ones that we did not cover, so that we could understand better the associations between these co-occurring issues in recently released women. So thank you, and a special thank you to the women in Worth who shared their stories, the other Project Worth team members, and my mentors, Dr. Melissa and Dr. Starr.